Can you believe it? This is one generation. You know, if we could go back in time 30 years, do you know what message we would have to our colleagues 30 years ago? How incredibly important this is? Our children who present with diagnosed BMIs that are elevated and those children are labeled obese, it's close to 50% of those kids have metabolic syndrome. And they're kids. And we have kids who are dying of heart attacks before they get to college. It's atrocious. It's lifestyle. It's our environment. It's food. It's stress. It's the chemicals that are getting dumped into our food. You know, you look at this trajectory of men in the United States who are veterans of the Vietnam War, who had high exposure rates to Agent Orange. And these men, they have now identified, who are rapidly accelerating in their prevalence of type 2 diabetes, they have now been able to tie the exposure to Agent Orange to the rapid acceleration of having diabetes in their 60s and 70s. And that exposure happened to them 40 to 50 years ago. Those are the persistent organic pollutants that we're talking about. You know those little, I don't know if you have the same brand, but have you had any of those little, they're like diffusers or air fresheners that you plug into the wall and they heat up and they put out a smell into the room? Do you have those here? Plug-ins to aerate and change the smell? There's persistent organic pollutants in those. No, you spray your body down, your clothing down with Febreze or some of these brands to take out the smell, filled with chemicals and compounds. Receipts. You touch receipts. You go to the store, you pay, you get your receipt. It's slippery, right? Dr. Rountree talked about this. It's slippery because of the bisphenol A. We have finally, oh my gosh, I have 4 kids, and my first baby was born under the era where we still had BPA in our baby bottles. Do you? It took about 5 years ago. We finally have mandated that our baby bottles are now BPA free. Because otherwise, our babies are consuming these plasticizers, which impact their metabolic trajectory, their diabetes, and their risk factors for a shortened lifespan. In 2005, the reports came out in the United States telling us that in 2005, the children that were 5 years old who were going into their kindergarten classes, grade school, were the very first group of children in more than a century to be living a shorter lifespan than their parents. Before that, we had an expanding lifespan, and within it, a shortened health span. And now, our lifespan is starting to shorten. It's the poisoning effect. Let's look at the body composition. We can gather information. This just shows you a 20-year window alone what's happened in the U.S. This is outrageous. This is what's leading to the crippling experiences financially within our healthcare system. So I am pleading with you, honestly, pleading with you to care enough, not just about your kids, but about your next generations, because it's not getting better at this point, it's getting worse. Their intellect, their learning capacity depends on their foods. The most important thing those children should be getting is DHA. Your baby brains depend on DHA. Your mothers need to be taking DHA through their pregnancies. Vitamin D, probiotics. These should be some of the most important things you gather over the course of this week. Your baby brains do depend on it, as do ours. Think about the trajectory of the chronic disease pandemic. And I want to show you, these are the 4 reasons. These are my 4 little people. It's one of the only times they are all on the same couch at the same time. They move a lot. This is the reason. Right here is the reason why I do functional medicine. I want healthy baby brains. My children at school teach the other kids to eat in a rainbow. My kids know more nutrition right now at 8, 6, 4, and 2. My kids know more about good nutrition than most physicians in the United States. And I wish that was an overstatement, but it's not. My kids train the nanny in how to cook their food. My kids tell on the nanny. They'll say, did you know that today we didn't have enough color? We only had a little bit of orange and a little bit of green today. Because they know every day they need to eat in a rainbow. Every day they line up in the kitchen for their sunshine drops. That's their vitamin D drops. Every day they know, I need my multi, I need my sunshine drops. And their chewy chewies, they call them. Their chewy chewies are their DHA, their fish oil capsules. They won't walk out the door without their chewy chewies in the morning. That's how we've trained them. That's their norm. It has to become the new norm. It cannot be KFC and McDonald's. That cannot be your new norm. That is not the investment that you want to make. So I want you to take a moment. I want you to look at these two men. They both have very high BMIs. By the U.S. standards, you'll see that the BMIs over 30 are classified as obesity. But what can you tell me about these two men? What's different about them? What do you see? So which man are we most worried about with our chronic disease? So do you see for the same weight, do you see the higher amount of muscle this man has on his frame? This man is much softer. He has the same weight to height. Exactly the same. This man's a bodybuilder. This man is on the road to heart disease and diabetes. Same weight to height ratio. Very different body composition. So, truncal obesity. Looking at truncal obesity. This is going to be one of the next areas that we're going to talk about. Now, we gather information very collectively. We want to look at a very well-rounded perspective with the BMI and reference that weight against other parameters. So I had mentioned this term to you before, metabolic obesity. Okay, metabolic obesity. This is our individuals who do have a normal or maybe even a low BMI, but they actually happen to have an increased fat storage around the midline. This is an imaging assessment. If you actually went in, cut into that patient and had the opportunity to really very closely go in and see what is happening within, you'll notice this very small amount of fat mass on the outside of the rib cage. Can you see that? This is an individual that has low subcutaneous but high visceral adipose tissue. This is high inner belly fat. In these patterns, we're concerned about two major issues. One, insulin resistance. Two, hyperinsulinemia, that elevated insulin response pattern. So again, subcutaneous fat mass. Okay, what I'd like you all to do is in your chairs, put down your pens. I want you to sit forward in your chairs. So sit forward, sit up straight, kind of curl forward. I want you to get out your pinchers. Okay? Please smile at me. Just a little bit, smile at me. I want you to flex your abdominal muscles. Flex them tight so your abs are hard. I want you to get your pinchers, and I want you to grab your belly fat. Nobody's looking, I promise. Grab your belly fat. What is sitting on the outside of your abdominal muscles? Can you pinch a little? Can you pinch a lot? What do you have there? Okay, now if you flex backwards just a little bit to your back oblique, kind of flex back, fire your muscles, and grab your back fat. Okay, feeling that area. Okay, this is an important area because in this area, especially for men, in this area, men tend to push out in this area and the fat mass moves out this way. That's an important thing to pick up. So I want you to think about this. Think about when you were 20 years old. And I know for some of you, that's longer than for others in this room. I want you to think back to when you were 20. And over the years, I want you to think about what's changed in your body composition in your years of aging as an adult. I want you to think about your waist. Has your waist increased? I want you to think about this. If your waist has increased since you've become an adult, and you have not very much to pinch, okay, your waist has gone up, but you don't have subcutaneous fat to grab, you should be much more worried than the other people in the room who've had their waistlines going up, right? And they can grab it. If you can grab it, it's subcutaneous. That's not so bad. But if you can't grab it, and you know your waist is getting bigger, that's an indication of internal belly fat storage. That's hot fat. Makes you more inflamed. You're more concerned about that kind of a trend. Okay? So we don't send our patients in for imaging. We don't send our patients in to have their midlines imaged. We don't do that in clinical practice. It's not practical. But what you can do is you can actually do measurements of your patients. All right, so I want you to think about this cascade. So starting way over here on the left-hand side, here is a man in this visual who is increasing his waist circumference. His waistline is changing. When that happens, the inner belly fat, not the outer belly fat, the inner belly fat actually has recruited to it white blood cells. Those white blood cells settling into the tissue, it's called tissue-rich macrophages. There are white blood cells that sit in and are modeled within that fat mass. You now have immune cells with the adipose cells cushioning the organs. And that's what's called VAT, V-A-T, visceral adipose tissue. That's hot fat. Okay? The inner belly fat sends out higher levels of inflammatory messages. Interleukin-6. I know you heard this from Dr. Roundtree this week. You end up producing higher levels of TNF-alpha, very important inflammatory messenger, which actually feeds back to the inner belly fat to store more fat mass. The ongoing messages that result from elevated inflammatory cytokines lead to atherogenic changes, leads to abnormal response patterns within the hepatic tissue. So the liver releases more triglycerides, higher insulin levels, produces more glucose through conversion, and the bad blood packages that Dr. Hyman talked about this morning, the ApoBs, we end up with small, dense LDL, which are more atherogenic. So when we look at the downstream impact of higher interleukin-6, it leads to higher CRP. We have increased messages of free fatty acids that become mobilized, which lead to the driving of increased triglycerides. So if you wanted to simplify your clinical screening process with your patients, the most simple thing you can do in the practice, measure the waist circumference run the lipid panel, look at the triglycerides. That's simple. Just start there. Simple. If you see that, higher waist circumference or a waist to hip ratio, high triglycerides, then go on and do the triglyceride divided by HDL ratio. Okay, triglyceride HDL ratio. If that number is greater than 3, you're concerned. The increased waist circumference, the increased triglyceride HDL ratio, that points in the direction of insulin resistance. You go on and you do more assessment. You check the CRP levels. You order CRP. You check the apolipoproteins. You look at the quality of those blood fats. So our concern starts with our visual inspection, and for him, we may be concerned about the downstream impact. Overall, I just want you to know that your waistlines are also increasing here. So when you look at your statistics, if you want to look at your journey and your changes, there's been a 20% increase in your waist circumference of men in your urban centers in China. We see a large increase taking place. That's one of the very first things that you want to be looking for. So, when you see a patient with more of an apple body, which is called android obesity, the least data that you really need to collect on those patients is their BMI. The least you document is a waist circumference. You check the blood pressure. You look carefully at the lipid profile and pull out the triglyceride and HDL. Take triglyceride divided by HDL. And then you look at your glucose levels. It's the least that you'll do. From a functional medicine perspective, when we see those patterns emerge, we think about the antecedents, the predisposing factors for those patients. Cardiovascular disease, type 2 diabetes, depression, dementia, or cancer. We look into the family history. Again, remember we call those antecedents. They go on the far left-hand side of the timeline. We consider and look for triggers or triggering events. These things activate the disease. We're talking about stress, high sugar, high carbohydrates, high glycemic index or glycemic load foods, and sedentary behaviors. Not moving adequately. And then what we call the mediators. They perpetuate, they drive the disease forward, so it keeps going and keeps going and keeps going. In those patterns, we're dealing with visceral adipose, inflammation, insulin, cortisol, and toxins. So this is a map of what we think about in the metabolic syndrome. The apple body type. We think about toxins from the gut, endotoxins, internal toxins coming from an abnormal digestive function. We're looking at the inflammation that's downstream from the abnormal body composition. We're looking at the mitochondrial abnormalities that Mark spoke of this morning that are tied directly into impaired insulin response. Environmental toxicity, very important subcomponent. Abnormal transport of our lipids, the carrying appropriately of our healthy levels of oxygen and oxygen perfusion to our tissues, issues related to sleep apnea. And in communication, here's the insulin receptor that receives the message at the level of the cell membrane, and from there sets off these messengers called kinases that mobilize the GLUT transport vesicle, works its way up to the surface of the cell, and delivers the glucose transporter so sugar can come into the tissue. This is what insulin resistance is. Insulin resistance is the abnormal insulin receptor site, or high levels of inflammation that disrupt the phosphorylation, the message coming into the cell. You can have high levels of insulin and high levels of glucose, and that's what is then translated into more inflammation and more stored belly fat. The insulin receptor is somewhat like a doorbell on a building. letting the cell know that there's a messenger that needs to come in. So when we look at the whole biomarker picture, what are some of the labs that you may want to think about? You want to certainly look at a more comprehensive glucose and insulin assessment. Or you may want to do a MET-SYN panel, looking at metabolic syndrome, ruling it in, ruling it out, and considering some of the associated parameters. Here is a structured standing list of what you would think about and consider in your different patients who are presenting with the apple body type. So I would keep this slide starred or highlighted so you can use it as a go back to sheet for taking yourself from body composition into labs. Now what about the pear body type? That's the gynoid body type. Well, you will often find that many of these patients have issues related to their adrenal, thyroid, or gonadal balance. You'll have the whole day tomorrow with actually one of the masters. Tomorrow you'll have Dr. Bethany Hayes with you. She is a master in understanding the important connections with detox and hormone balancing, the thyroid and adrenal associations. This whole new emerging term now called infective obesity, where people can have low-grade infections, either in the gut or in the bone, in the jaw, an abscessed tooth, sinus infections, where chronic infections produce endotoxins, which accelerate the storage of body fat. Infecto-obesity, it's a new term coming through in the literature, especially for patients who've really struggled to lose weight and they can't. Detox abnormalities, gastrointestinal issues like a permeable gut, intestinal permeability, and the prevalence then of either a food sensitivity or a food allergy. So these are things you should step back and think about in your patients who are struggling to lose weight, who are holding more of their weight below that waistline. So nutrition and hydration. When looking in these areas, we certainly see the food allergies, food sensitivities play a big role, but the map for the pear body type looks a bit different. You'll find that food reactions are very common. Medications will be common triggers for these patients. Do you have patients who come in and tell you that no matter which medication they're prescribed, they get side effects? Do you have patients like this? Patients who have high adverse drug reactions, right? That's pointing back to liver detoxification problems. Okay, so that's a trigger. Look for that pattern. You'll see it more common in the pear body than you'll see it in the apple body. These patients have a lot of assimilation gut issues. They have a lot of toxicity issues. And they have a lot of problems with adrenal, thyroid, and gonadal hormone balance. And then I've given you a summary list of labs that you may want to think about, all of which have been discussed so far over the course of the last few days. So I started with you earlier in the week talking about the different classifications of body type, because one of the ways that we can move to the right dietary approach for the patient is to start by looking at the body composition and then move closer and closer towards transitioning the food plans. So again, remember, in patients with the apple body, go to the glycemic food plan, the low glycemic food plan. That's exactly what Dr. Mark Hyman's book references. His blood sugar diet, his blood sugar solution book, references solutions from the low glycemic food plan. In patients who are struggling with weight loss, who happen to have the gynoid obesity or the pear body type, these are going to be the areas where we're going to be dealing with lower levels of allergenicity. So on your menu plan listings, when you go onto your toolkit, you'll notice a whole section of nutrition. Nutrition handouts, nutrition resources. You have two handouts that are actually very easy for you to pull and work from: the low glycemic impact food plan and the comprehensive elimination diet plan. And then again, keep in mind the phytonutrient spectrum is great for everyone. Absolutely great for everyone. So to my Hong Kong team, can I ask you questions? So I had the privilege of meeting this group of nutrition experts a year ago, February last year, January. So a year ago, they are all here from Hong Kong. They are actually working, are you all still together at Neoderm? In a remarkable facility in downtown Hong Kong in Times Square building. And one of the greatest challenges of my entire naturopathic medical career was figuring out how to help them write an elimination diet for Hong Kong. You remember the pain and agony that we were going through, and you're still working through with Kara Fitzgerald there? The challenge we found was, as Dr. Hyman mentioned a few days ago, is what happens when you take people off of gluten and you take people off of rice and you try to figure out what's left for them to eat, right? Because the traditional elimination diet is going to be one in which you eliminate the most common foods people eat. It's a challenge. In the States, we pull them off of gluten, we pull them off of wheat, and we put everybody on rice. So what do you do here? Right? It's a challenge. And we were struggling, weren't we, to find gluten-free alternatives. I think we found one store in downtown Hong Kong, one store that was easy for people to go to and find gluten-free alternatives. These are solutions that you want to bring in to your areas, to your grocery stores. You want to ask your grocery stores to get you more resources, the amaranth, the quinoa, to start to try to bring in some of these grains that are considered low allergy. Because if someone's eating rice and rice noodles all the time, not only does it have a glycemic index that's high, but if they have a permeable gut from drugs or antibiotics or too much sugar or too much stress, there's a breakdown in the lining of the gut. And eating all those rice-based foods lead to increased food sensitivities to rice. So it makes it more challenging. So what I'm telling you is when you look at the elimination diet that is typically used around the world, I want you to think about the amount of rice your patients may have eaten over the course of their life and ask them to limit the rice. You don't want to move into more and more rice if they're rice sensitive. It goes with the permeability problem. Probiotics, glutamine, deglycerinated licorice extracts, aloe. These are the things that heal and soothe the intestinal tract and can reverse the permeability problems. Usually you want to go into an elimination diet about 2 to 3 weeks if you can. 3 weeks would be wonderful. If you can go longer than that, it's even better. Then you slowly start reintroducing the foods. So these are the most commonly used handouts that you have on your toolkit. So I wanted to make sure that all of you know that in the apple body, lean to the low glycemic impact food plan. In the pear body, lean to the comprehensive elimination diet. Okay. So assessing for truncal obesity. 3 main ways that we do this. We're going to look at the midline, measuring the waist to the hip, and then looking at the patterns and the relationships of the waist to the height. So very simple to do, very easy to do. So can I have a volunteer? Can I have a volunteer? Yes, no, maybe? Come on up. I'll take anyone. I'm blinded by the light. Sure. Okay, can you take off your jacket? Okay. Perfect. So you're on deck. So you're next. Okay. So how do we do this? So how you do the measurement. So come on up, ladies. Come up in the front. Okay, I'll do you first. So all you need is a tape measure. And when you're going to do these measurements, and I want you to feel for these spots while you're sitting down. Okay, so on yourself, I want you to find these bony spots. So when you do a measurement of the waistline, what you're going to do is you're going to locate the bottom of the 10th rib, which is right here. So I want you to slide your hands down the side till you fall off your rib cage, and the bottom of the 10th rib is the first place that you take note of. Then you're going to slide your hands down until they rest on the top here of the iliac crest. So the bottom of the 10th rib, the top of the iliac crest, you split that difference in half. Okay? Did you find yours? Find your own spot? Why don't you stand up and do it? Stand up. Stand up. Much easier. Stand up. Come on. You've been sitting for 4 days. Stand up. Okay, so how you do this. So I'm going to start with you. You turn the patient away from you when you measure. So I want you to slide your hands down, find your bony landmarks. So off the bones, what you'll end up doing is you'll feel down the side of the rib cage until your hands fall off the bottom of that 10th rib. So I always take my second finger and I hold it there. Okay, so that's going to be the upper spot. Then we want to feel the top of the iliac crest. Then I get my two fingers like this on those two locations. Now some patients have a tall trunk and I can't reach. So I have to feel those two locations and find the halfway point. So what you're going to do is find your two spaces, and then it's nice and easy to just drop your fingers into the middle, the midpoint. I'm going to have you step back a moment so they can see. And the hands drop right over the top. So I scan down till I hook. I feel for the top, and then my thumbs come together. And that's the easiest, fastest way to find the right spot. Okay? So what I want you to do is I'm going to show you how to do the measurement, and then I actually want you to pair up with somebody, and I want you to find these bony landmarks, okay? So the first thing we're going to do for her is I'm going to find the locations, come to the middle. Now I always measure from the back because nobody likes to have their belly touched. Okay? No one likes to have this measurement done. It's not fun for anybody. And if you're poking here, it's not very professional. Okay? So you come to the back. You find your location, and with your tape measure, what you do is you start right over the top of the spine. The reason is you want to be able to get your fingers in when you come all the way around. Now, you don't want to be hugging your patients. Okay, you don't want to be putting your arms around the patient. You need good technique. So you start over the top of the bones. I'm going to turn you this way. It's called the spinous process. Then I'm going to come to the side and I'm going to check my two bony spots, and I'm going to ask her, can you put your thumb here and hold this spot? Now see, now I'm free. And I can walk all the way around her. I can check my locations. And when you come to do the measurement, you now ask the patient, can you please put your arms down? Arms down. I got it. Arms down. Take a big breath. Arms down. Arms down. Tell her arms down. Okay. Now tell her arms down. Now tell her take a big breath in and let it out. Go. Let it out. There. So when she lets it out, that's when you do the measurement. Now for women, you want that waist circumference, it needs to be 80 centimeters or below. For men, 90 centimeters or below. Okay, she did good. Can you clap for her? Very good. Not done yet. You're not done yet. Come back, come back. Okay, now we must do the hip. So now we're going to find the greater trochanter. Okay, you feel yours. While you're standing up, find that big bony protuberance at the top of the femur. Okay, so right over on the side. You do not measure from the back. Do not measure from the front. From the side only. So you start over the bone. And I'm going to have you put your hand there. Thank you. Good. Great. Okay? There. Okay? So now you take those numbers. She's going to take her waist divided by her hip. Waist divided by hip. Waist divided by hip is a waist to hip ratio. Okay, waist to hip ratio. That's what you want to go now. Write your numbers down. Write your numbers down. So with women, when you do a waist to hip ratio, less than 0.8 is your goal. And for men, less than 0.9 is your goal. Okay? Do you want to come up? Let's do it again. Come up. No good? Are you rejecting me? I won't tell any numbers. Okay, turn around. Okay, so again, come down, feel, back, hook, go. And I'm going to have you put your hand right here. Great. Okay, big breath in and out. Okay, all done? Right there. Okay, and here. Hold. Okay, now do the math. See how fast? I want you to see how fast. So it takes about 1 minute to do. And on the break, I'm going to leave this up here, and you can come up and you can do your own. Okay? Come up with a partner. You can do yours if you want to do them. Okay? So very easy to do. It's free. Right? It costs nothing. Just takes 1 minute to do. So do it. Okay? That one thing is very important for the metabolic syndrome diagnosis. So the numbers, when you're looking at your ranges, ideally, you definitely have to, for the cutoff point, for the diagnosis. For the diagnosis for women, 88 and below is perfect. Okay? 88 and above means increased waist circumference, check mark for metabolic syndrome. Okay? Memorize. Men, 102. Lower is better. Okay? And when we look at the waist to hip ratio, memorize these. You want to do the waist to hip ratio. Because overall, you are of a culture where your people are smaller in general. And you want to do the waist to the hip. Don't stop at the waist. That's not good enough. You must do the waist to the hip. That's much more accurate. Okay, you need the waistline for the diagnosis. But the waist to hip is a much better clinical indicator for you. Okay? So don't just do the BMI alone. Don't just do the waist to hip ratio alone. Because you'll miss the whole picture if you only do one thing. So look at all the patterns. And then the last that we look at is there's a very effective way that you can test the body fat. It's called bioelectrical impedance analysis. I'm not going to teach you about that today. I do workshops usually that are 4 to 8 hours for how to do that. I'm going to show you the big picture so you can look at Dave, the case, together. With BIA, this is bioelectrical impedance analysis. You are sending a frequency through the tissue, and it penetrates the tissue, and it gives you a reading called the resistance and the reactance. Okay, those two numbers get run through a computer program, and it tells you the body fat percent. Okay, that's how BIA works. Very simple. You either stand on a scale and hold your hands on a bar, or you lay down and there's pads on your hands or your feet. There's different types of equipment that you use. It has to run through the middle of the body. You have to run through the middle of the body, so you're testing the body fat here. Not just hand to hand, not just foot to foot. You've got to run from the hands to the feet and back through. So there's different types of equipment. There's scales where you can just stand on a scale. Those are not good because they're just doing the lower part of the body. That's not good for a medical practice. It's fine to have in your bathroom, but that's not good enough for a medical practice. So you go through the body. Okay, so why do we do BIA? You do BIA because it tells you about the body's hydration and where the water is positioned in the tissue. You can get a body fat report. You can get a muscle-related report. And you know how many calories that patient burns on a daily basis. So you can help get their diet very specific to their needs. So we are going to take a 10-minute break. Want you back in 10 minutes, and we're going to workshop together Dave. Okay, and so we'll probably be done about 5:30 today. Okay, so let's just do a 10-minute break. Okay, short break, come back.